Bismillahirrahmanirrahim. Assalamu alaikum and good morning, ladies and gentlemen. We'll begin with the recitation of Holy Quran. May I request Dr. Fahad Tariq to please come and recite few verses.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ألف لام ميم ذلك الكتاب لا ريب فيه هدى للمتقين الذين يؤمنون بالغيب ويقيمون الصلاة ومما رزقناهم ينفقون والذين يؤمنون بما أنزل إليك وما أنزل من قبلك وبالآخرة هم يوقنون أولئك على هدى من ربهم وأولئك هم المفلحون صدق الله العظيم.
Jazakallah. On behalf of Pakistan Society of Gastroenterology and GI Endoscopy Sindh chapter and Chairperson Department of Surgery, Dow University and Medical Superintendent Civil Hospital Karachi, I welcome you all to the second hands-on colonoscopy training course. It's my privilege to welcome our international faculty for the course. We have with us Dr. Waqar Ahmed, who is a consultant physician and gastroenterologist, Gannad Hospital, UK. Then we have Mr. Paul Hagen, who's a consultant colonoscopist, King's Mill Hospital, Mansfield, Nottinghamshire, United Kingdom. And lastly, our national faculty, Dr. Saad Khalid Niaz, who is a consultant gastroenterologist and the visiting faculty and director endoscopy, surgical unit 4. May I now request Professor Saeed Qureshi to please come and say a few words.
Assalamu alaikum. It is my privilege to welcome all of you to this second hands-on course on colonoscopy, where we try and impart you the finer skills of colonoscopy. We try and improve on your skills. I would like to thank Paul Hagen, who is here for the second time round, and Waqar, who, well, we cannot count his visits. They are innumerable, and they deal with colonoscopy, ERCP, and various workshops dealing with the Pakistan Society of Gastroenterology. Again, I would like to thank you both for being here again with us this week, and I hope you have an enjoyable visit to Pakistan. Dr. Saad Niaz, as ever, is deeply involved and organizes this workshop along with Sajda, and again, both of them I would like to extend my gratitude, and to the rest of the staff of the endoscopy unit who participate actively and help us, both us and all of you, in getting the most out of this workshop. Thank you very much.
Thank you, sir. Now may I request Dr. Saad Khalid Niaz, who is our course director for this second hands-on basic course on colonoscopy, to please come and say a few words.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. It's an honor to have all in Waqar here, and we are really very happy to start our second hands-on colonoscopy course. Just give you a quick overview of what we do and why is it different from what else is available. Hands-on training is really, in my opinion, not available in Pakistan at all. We are very grateful to Paul and to Liverpool for allowing us to use their entire curriculum and help us and guide us in organizing this course, without which we would not have been able to do this. This is a 3-day course, as you all know, and we'll have some theoretical, basically some directed lectures, and then after that we'll go on to dummies, and in dummy we'll hopefully demonstrate to you simple principles of doing colonoscopy and try and create some concepts about looping, etc. Things that make colonoscopy difficult. And we hope that by the time we finish with the dummy and when we go on to the live cases, you'll be able to appreciate and understand what you're doing more. 3 days will not make you a colonoscopist. 3 days will give you principles, foundation to become a good colonoscopist, to know what to do and to know what not to do. I think both are very important. So we hopefully in the next 3 days will be able to do that. Just briefly, here in Surgical 4 in Civil Hospital Karachi, for some of you who've come from outside Karachi, we are probably one of the busiest centers with advanced endoscopic procedures in the country. We are now clocking about 1,000 ERCPs a year. I'll hopefully by the end of the day I'll tell you how many colonoscopies we do. I don't exactly remember. We are constantly training people while we are doing this. And this hands-on course is something that is really close to Waqar, my heart, as well as Sayyid Qureshi Saab's. So we all really wanted to do this, and this is basically for people who are in training in Pakistan, because these are expensive courses, number one, in UK. Visa issues, traveling, all that costs a lot. So what we are trying to do here is bring this module here from UK, which, to be honest, only a few years ago was just a dream. But it has become a reality. And the good thing, Paul, is that in this particular course, whatever happens from today onwards has been organized by Sajda and Shahryar. So my job was basically to get Waqar and Paul here and be present here. So whatever good takes place here, the credit is to Sajda and Shahryar. And similarly, whatever goes wrong is to them. So I was just telling you that we want this to be interactive. We want you to participate. Please ask questions, be informal. This is not a formal course. We have a very small, that's the whole idea. We can have 25 people sitting here, 50 people sitting here, and we can demonstrate, and that's how some of you may have seen courses done. This is not how it's done. You'll be one-to-one while the rest are seeing you. But while you're one-to-one, you don't have to become conscious. You have come here to learn. So any question, no matter how silly you think it is, may be very beneficial to everybody else. So please ask questions, please interact. There is no point sitting quietly, and share your experience with us. I'm once again thankful to Paul, Waqar. I can't thank Saeed because this is all his department, and I only can thank him for allowing me to be here. And thanks to the 3 pharmaceutical or medical companies that have supported us, Feroz Sons, Getz and Olympus, to help organize this course, which brings down the cost. Otherwise it would be very difficult. With that, we will start. Okay.
May I now request Dr. Waqar Ahmed to please come and give a brief introduction to the course.
All right, thanks, Sajda. First of all, my thanks and gratitude to Saad, Professor Saeed Qureshi, and all the staff here, like Sajda Shariar, who very kindly invited us for their kind hospitality. It is like coming home for me because this is, I've been a regular visitor here, so I'm one of the home staff. I'll start off with the boring stuff, so all the theoretical background that you need for the course. And once you're finished with me, then you won't hear much theory from me. It will be all practical stuff then, right? So we'll start off with what we call the clever or the boring stuff. Right, the learning objectives for this module. We'll go through some of the basic things that we need to know about, performing colonoscopy safely and efficiently. And the important thing is to get a proper consent and informed consent. Then we need to discuss the indications and contraindications for colonoscopy, because whether we are doing it for the right reason or not, or whether it is at all needed. Sedation practice, which is becoming very important these days, because a lot of your morbidity and mortality can be associated with inappropriate sedation or sedation given wrongly. And I'll briefly touch on diathermy theory and practice. Right, first of all, consent. Frequently asked question, what constitutes an informed consent? What risks are quoted for colonoscopy? Because if you have to give them an informed consent, the patient needs to know what he's going to go through and what are the potential risks involved. What about withdrawal of consent during the procedure, and what do's and don'ts? So the key components of informed. Main principle of a consent is that the patient should have sufficient information to understand the procedure, its benefits, and the harm that may arise, so the possible complications. The patient should be in a fit state to understand and retain the information, and at the same time properly assess that information. He should be able to, when you talk to him, you should understand what you are saying to him. You should be speaking the same language. He should be able to retain that and should be able to assess that information and make an informed decision on the basis of that. And also at the same time, he should be allowed to communicate his wishes, whether he wants to have the procedure done or whether he wants any modification to it. So this should all be part of your consent procedure. This is how it should be done. Not that you bring the patient into the endoscopy room, ask him to quickly sign on the dotted line and get on with it. So this should be, a consent should be carried out in a room outside the endoscopy suite, so that they are not under any type of coercion. And the patient is coming, there's a thing about mental capacity, which is, that they should be competent to make a decision. Yeah.
And then you send them for endoscopy.
Yeah.
When you actually decide that you need to do a colonoscopy.
Yes, sir.
Can you start the consent procedure?
Yeah, you can do it over there.
You can take a consent right at that time.
Yes, sir.
Rather than, because a lot of us don't have endoscopy facilities where we can actually go out and have a separate room. I'm sure you. Yeah.
In fact, no, that is perfectly valid consent. In fact, what we do in our unit is, and I'm sure a lot of people do, is postal consent. We've got information booklets which give complete information. This has been ratified and validated by British Society of Gastroenterology. And you send out that information sheet pack and consent to the patient. And then there's a detachable consent form where the patient signs his consent and the doctor then reconfirms that. So you can either consent in the clinic room or send out a postal consent form. The important thing is that they should have the opportunity of weighing up the information, making an informed decision, and it is not something which is sort of forced at a time. If it is a medical emergency, you can carry out the procedure without a consent on the basis of medical emergency. So it is not restrictive. Other important thing is that the patient is not under any pressure, duress, or forced into a decision. Patients have the right to choose alternatives. During the consent process, you can tell them that, well, if you don't want a colonoscopy, you can have a barium enema or a CT colonography, but you can also give them the limitations of the other procedures. So, and they have the right to refuse treatment or withdraw their consent at any time. So the useful tips, it's always nice to have a privacy, that the patient is not made to make a consent in public. So, we always reserve a room where then there's a structured format that we tend to use. It's called EMBRACE. It's an acronym for what the next slide will explain to you. And it is important again to clearly specify the risks of the procedure. So it is a good idea to know what the possible complications are and what the incidence of those complications are. And always ensure opportunities, you provide opportunities for questions, and always ensure intravenous access. Secondly, all this should not take ages. It should be completed within 5 minutes. So the more you practice it, the better you get at it. This is what EMBRACE stands for. E for explanation of the recommended procedure, which is colonoscopy. M is for motive or reasoning behind the medical recommendation. B for the benefits. R, risks, alternatives like doing nothing or a CT colonography or anything. Complications. Side effects is usually E for the side effects. Side effects is usually the effects of drugs that you give, like sedation. Now this format you can use for any type of consent, not just for colonoscopy. Now, what are the risks that we quote for colonoscopy? Well, normally we don't tell them during the consent procedure about death as a first thing, but if they ask you directly whether I can die from the procedure, then the answer is yes, but you should be in a position to give them a statistical quote, and it's about 1 in 5,000 to 1 in 2,000 from various series that have been quoted. Perforation is another well-recognized complication which can occur in colonoscopy or any endoscopic procedure, and for colonoscopy it's about 1 in 1,000 depending on, it can be less than that depending on the type of procedure you are undertaking, because if you are taking out big flat polyps by endoscopic mucosal resection, the risk of perforation is much higher than 1 in 1,000. 1 in 1,000 is for the random colonoscopy. So, and then significant hemorrhage. Again, the risk of complication for hemorrhage is around 1 in 500, but it can vary depending on the type of procedure. So if you are taking out a big polyp with a big stalk on it, large feeding vessels, there's a high risk of hemorrhage. Similarly, if the patients are on anticoagulants, they've got liver disease, or they are on antiplatelet agents, the risk of hemorrhage is significantly higher. Now, what happens if your patient withdraws consent during the procedure? He gets severe pain and says, stop, I don't want the procedure. What do you do? Well, the background to that is that competent adult patients are entitled to refuse treatment, even where the treatment would clearly benefit their health. Even if you are 100% sure that if I carry out this procedure, it's going to benefit him, I'm going to take a big polyp out or diagnose a cancer for him which can be treatable, but if he refuses it, then you've got no right to continue. So, withdrawal of consent during the procedure, if the patient is unsedated and the patient is fully conscious with all his faculties intact, then you terminate the procedure immediately and record event in the notes. If the patient is sedated, then you can give him the benefit of the doubt that he might be a bit disinhibited or not quite with it. So the endoscopist must act in patient's best interest. You pause, you try to deflate the colon if possible, take out any loops that are there, make it more comfortable for the patient, consider additional sedation or analgesia, and if the patient then complies with it, then you can go ahead and do it with the patient's permission. However, if the patient still is in great discomfort and does not want to continue the procedure, then you terminate the procedure. So basically, in the do's and don'ts of consent process. So always good idea to read the patient's notes and the background history. Be familiar with your local consent form and information sheets. Always a good idea to introduce yourself to the patient and use a structured approach to consent, which is the embrace format. Check for understanding, make sure that the patient has understood. If the patient, speaks Pashto and you give the consent procedure to him in English, then obviously he wouldn't have gone through. So try to get a translator or interpreter if he doesn't speak the same language, and always allow time for patients to ask questions. Don't forget to ensure privacy. Don't take up consent in public. Don't use too much jargon, medical terms. So that applies to any medical counseling or of the patient. And don't forget to keep an eye on how long the consent process is taking. It should not take forever, because if you are doing it properly on a regular basis, you become more and more efficient at it, and you should be able to complete all this within 5 minutes. And don't forget to ask about allergies, heart valves, or anticoagulation before you start the procedure. Indications for colonoscopy. One of the important things I always tell people is abdominal pain per se is not an indication for colonoscopy. You do not do colonoscopy just to investigate abdominal pain. It is inappropriate, right? So the indications for colonoscopy are rectal bleeding of any sort is an indication. Iron deficiency anemia. Iron deficiency anemia is an indication for colonoscopy. And in case you've got a patient with iron deficiency and is asymptomatic, and you are only allowed one procedure out of OGDR colonoscopy, I would go for colonoscopy, because the yield in from a colonoscopy is much higher. Suspicious appearances on barium NMR CT scan and assessment of colitis or Crohn's. So in inflammatory bowel disease, you would perform colonoscopy for 3 particular indications. One is to determine the extent of the disease as to how proximally it extends, your ulcerative colitis, from the rectum onward. The activity of the disease. In case the patient is having frequent loose bowel motions, you want to find out whether it is due to active colitis or whether it is due to fecal loading of the colon or irritable bowel syndrome. So activity of disease is an important indication. And surveillance. Once they've had colitis for over 10 years, these patients need to have regular surveillance colonoscopies to look for bowel cancer or dysplasia. Again, continuing with the indications for colonoscopy, unexplained diarrhea or change of bowel habits to looser, more frequent stools lasting for more than 6 weeks. I mean, acute diarrheas, you don't normally do a colonoscopy because most of the time they are infectious diarrheas and they would sort themselves out within a week or 2. But if the diarrhea persists, then that is a definite indication. Change in bowel habit in any direction, diarrhea or constipation in anyone above 60 years of age, it is a definite indication for colonoscopy. Or if the patient, the change in bowel habit is associated with rectal bleeding, a definite indication for colonoscopy.
Can I just
Yeah.
One point about this activity in inflammatory bowel
Yes,
disease.
yeah.
What has been seen here is that I've had patients who had, I just saw somebody only 3 days ago who had 5 colonoscopies in the last 2 years for his disease activity.
I think that is silly.
So he came to me and he's actually moved from another city from the north to Karachi. And he says, I've been recommended to see you. When do I have my colonoscopy? And I said, you had ulcerative colitis. And I said, how is your bowel? It's okay. I said, why would you need a colonoscopy? He said, I've been told I need it every 6 months. And I said, why do you need it every 6 months? It's because you need to see whether it's getting better or not. I said, why do I need to see whether it's getting better or not? You already told me you are better. So it took me literally 5 minutes to convince him that he does not need colonoscopy, for God's sake. And I had to be blunt, and I said, I'm sorry, 4 out of the 5 that you've had are actually unnecessary.
Absolutely.
He responded to the first treatment. So when he's saying activity, I think it's very important to know that you're not just looking at whether the disease is there or not. What you're looking at is if the patient is actually not getting better, or you're confused whether it's the symptoms he's having are because of activation of his colitis or non-responding to the treatment, or is actually because of something else. And that's what is the point being made here. For routine Crohn's and colitis, for God's sake, you don't need colonoscopy. The first colonoscopy is for diagnosis, and hopefully you'll be able to see the extent at that side as well. The next you only do if you're worried, or if the patient is very severe and you're not sure what's happening. Or I think it's when you go to the surveillance thing, which starts at 10 years.
10 years.
So it's very important. If you look at a survey here in Pakistan, I can tell you most politics have colonoscopy. At least, 50% of the colonoscopies are really not necessary. That's one point. The second point is in the audit that you're coming to.
Yeah.
Do we know how many of the patients who've undergone colonoscopy are actually correct indications, or indications that could be justified, or how many are actually done for incorrect? Do we know?
I think it depends on the series, where you audit them, because if there is like a lot of the hospitals now have a validation and vetting service. We do it, and Paul, I'm sure you do it as well, where all the request forms for colonoscopy, for any type of endoscopy, are validated, are vetted by a gastroenterologist. And we weed out a lot of unnecessary procedures. And this has really cut down our inappropriate indication, because in the past, I wouldn't even know, and somebody would come on the table and be colonoscopy for something very stupid indication. So now with the vetting and validation procedure, we have tightened up the screws on it, but still this slips through the net.
One of the points is that if you look at, I haven't got access to the private sector in UK so much, but I see a lot of patients from the US, and if you look at the indications for the private paying patients, is unfortunately is different.
That's
those
true.
who are coming in the non-paying list. And I think that's something that highlights the point. Your indications remain the same, no matter who the patient is, whether the patient's paying or not paying. But unfortunately, if you actually look at the list of those who are paying, you'll always find a lot of those patients who actually would not fit the criteria that is being mentioned. I think it's important here, sorry Bakara.
No, that's okay.
It's important for you people here to know that your accountability is not here. Every wrong procedure we do, we will be accountable up there. If you don't care about the accountability there, do it right, left and center, nobody will question. All the consent thing and everything else in Pakistan becomes, you can go in the bin. Come on, let's do it. You need it. You can scare the patient. Just tell him the word cancer and he will say, put scope anywhere you want. Okay? So I think it's important to remember that, and that's what I was trying to because we don't have accountability, whereas you're coming from a system which has gone a long way from not having accountability to having a lot of accountability, which puts some pressure. And we work in a system where you don't. So I think it's important. Sorry.
No, that's fine. That's a very good point. And in fact, please feel free to chip in, because this is important.